Kate, you want to start with a short introduction for me, please?
Hi, I'm Kate. I'm BRCA2 positive, found Tracy 2 years ago, I think. And here I am.
Thank you, Kate. Rebecca? If everybody could do like a short 30-second introduction, I'll call your names if you don't mind, just to do an introduction so we can put some either faces or voices to your name would be great. Cindy?
Hi, Dr. Perez. Glad to see you here.
Cindy.
Everybody
knows who Cindy is. Everybody knows who Cindy is. It doesn't require introduction.
And Tracy and Kate have been doing a great job with the BRCA Strong. I'm so proud of her.
Cindy, you want to tell like a 30-second introduction of like who you are, maybe about the book?
Okay, you're so cute. I'm a breast cancer survivor, 3-time author, and I'm happy to have Tracy in Experts in Pink. That's the latest book that's out, and you can get it on Amazon and Kindle.
Perfect, thank you. Danielle?
You're welcome.
Hi, my name is Danielle. My sister Tammy informed me of this group, and I was diagnosed in the summertime. Started with chemo and it didn't work well, so I just had surgery the other day, or a week ago, and I'm recovering and eager to hear any information that can help me.
Perfect. Well, thank you for joining.
Thank you for having me.
Tammy?
Here to learn and be supportive. And I'm so inspired by all of the stories of your resilience and strength.
Thank you so much for joining and your support. Rebecca? Paola, welcome. Do you mind doing a short introduction?
Hello, how are you?
I'm good. How are you?
My name is Paola. I was diagnosed with stage almost.
We lost you.
Driving.
We can't hear you, Paola. I think it totally went out.
2.5 months in remission. And Alejandra, mi hermanita, is Sandra Gonzalez. She's your patient.
Oh, of course, yes.
She's gonna
Whole
go
world.
see you. She was gonna be, she was the one who actually grabbed me by the ear and said, "You have that lump for many years, so you better go." So you know the stage that she was, and she was my rock, and she still is. And this group has been very supportive, and she's been the best for me. So
That's great.
it makes me like tear up right now because her birthday is on this Sunday coming up. So her and I were being like this, like tremendously. So gracias for taking care of my older sister.
Of course, pleasure.
And it's nice seeing you, even if it's like this right now. But hopefully one day we can meet each other.
Of course, of course.
Yeah, my stepsister too, who never got a mammogram till after the BRCA fashion show I was in, and she was 51 years old or something.
Wow. The funny part is my sister and I, we both got diagnosed at the age of 47. Exactly.
Oh, wow.
And I was, of course, my stage was higher because I did not take care of myself. So I'm good. I'm fighting, and I love this Tracy and Kish and everybody in this group has been like the bomb.
Thank you, Paola. Good to see you. I know we have somebody with the name of Mal152. If you want to introduce yourself, I just want to make sure that I call you by your name.
Hi, it's Myra.
Oh, that's so interesting. I'm like, wait.
I'm hooked on it. I just don't know why my face doesn't appear, but it's okay. Let's see.
Thank you for joining us.
Let me see if I find me and I can fix it. Hold on. Let's see. Start video. Okay. There we go. Yay!
Beautiful. Awesome. Thank you for joining us again tonight.
You're welcome. I can't wait to hear Dr. Perez. I love her.
Perfect. So what I'm going to do is I'm going to put everybody on mute and then we'll get started.
Okay.
So I'll share my screen now.
Yes, go ahead. Good evening. Welcome. Thank you, everybody, for joining. I'm Tracy Milgram-Posner, the founder of BRCA Strong, where we educate, inspire, advocate, and support survivors and thrivers to eliminate the feeling of isolation and help you feel whole again. Our mission is to fund women post-mastectomy garments to help you feel whole again. During COVID-19, we are still funding post-mastectomy garments and as well sending out care packages. So if you or your family member have just been diagnosed with either the BRCA mutation or another mutation as well, and breast cancer, you can feel free to reach out to myself or Kate, and we'd be more than happy to send you a package. Tonight, we have Dr. Perez coming on to talk about management of breast cancer during the COVID-19 pandemic. Thank you so much for your time. We appreciate all your support.
Thank you, Tracy. Thank you all for being here and for the invitation. So this is going to be a general lecture about the things that we've done differently during this pandemic. Of course, if we want to go into more details about breast cancer, I'm happy to do that as well. But this is a different world for all of us. So things look a little bit different, and we've had to change many of the things that we do routinely. So let's go over some of the aspects. You all see my screen, okay?
Yes.
Okay. So COVID-19, I'm sure you're sick and tired of hearing this word. We all are. So it stands for coronavirus disease 2019. It's a new type of coronavirus, SARS-CoV-2. SARS, this class of coronavirus, they're been with us forever. It's just another cause of common cold. But this one is a little bit different. It's a new virus in this class of coronaviruses. Coronaviruses, all the kids get them, and it's just a common cold. But this one is different, as we all well know by now. First detected in China, in Wuhan, China, in 2019, in December. I remember hearing about the first case December 31st. But it took a while for the World Health Organization to declare this a pandemic, and that was March of 2020. We know that COVID-19, the incubation period is 2 to 14 days, and that's important because that's the time that you need to, when you're exposed to the virus, that's the time of for quarantine, 2 to 14 days. So what are the symptoms of COVID-19? So cough, sore throat, difficulty breathing, muscle aches, fatigue, loss of smell and taste, and GI symptoms like diarrhea. These are very similar to many other viruses like the flu, except for the two that are typical of coronavirus is the loss of smell and taste. So if patients, if anybody develops lack of smell or changes in taste, that could be a sign. Even in some third world countries, the test that they're doing is they make them smell vinegar when they come into work or when they come into, the classroom, and that's a way to screen them, an easy way to screen them, because it's typical of of COVID-19, that one. And the second symptom that is also very typical is the difficulty breathing. The way they describe it is with this heavy sensation, like an elephant on your chest. Those two are very typical of COVID-19, because the others, of course, any flu, any cold can give you the same symptoms. There are two ways of detecting COVID-19 in the body. So we have the antigen test that tells you exactly if you have the disease, and this is for acute disease. So if you have the symptoms, you go and get tested. Those are the nasal swabs. There are also blood tests, PCR, different types. But the antigen is going to tell you if you have disease right now. And then the antibody is going to tell you if you had the disease. So if the patient had the disease 2 months, 3 months before, you can have antibodies. The question right now is for how long you keep those antibodies, and that's what we don't know yet, because technically you're protected while you have the antibodies, but they could last 3 months, and then you are susceptible again. And some people even say, well, why check them? Because you still have to be careful and you can get reinfected again. So those are the two types of tests that you're gonna see available. So who is at risk of developing COVID-19? Older adults, and not just developing, because we're all at risk, but who's at risk of having worse outcomes of coronavirus? So older adults, patients with chronic lung diseases, cardiovascular diseases, especially hypertension, kidney problems, diabetes, obesity is one that is associated with high mortality, HIV or any form of immunosuppression, smokers, of course, because they usually present with lung disease as well, active cancer, so patients with metastatic breast cancer, patients that are undergoing chemotherapy, active treatment. And we consider that period of time after chemo, about 6 months, that your immune system is really immunosuppressed, because that's the most common question we're getting right now. Am I at risk just because I had cancer 3 years ago, or are survivors at risk? And we haven't seen that in clinical trials, granted that we have very little information on, we have very little data because obviously this is a new disease, but we don't think that the patients, that survivors, long-term survivors, are at a higher risk than anybody else. So we tell patients that the highest risk is on active chemotherapy, immunosuppression, or 6 months after. After that, the risk is very similar to the general population. The only thing that we've seen different with survivors is that let's say you're doing well, you had cancer 4 years ago. When you get COVID, you're not at increased risk of getting COVID, but when you get COVID, you can have an increased mortality. That we've seen in one clinical trial that was published in The Lancet, in a big magazine, a journal that we have, and it showed that survivors could have a higher mortality. So something to pay attention to, but again, we have very little information, not really to make conclusions. Bone marrow transplant, again, any form of immunosuppression. So in patients with cancer, again, any form of chemotherapy, radiation, targeted therapy, that's going to increase your risk. Also, cancer can also affect the organ function. So if you have problems with your liver, with your lung, with your kidneys, due to cancer or due to the treatment, that your risk is also higher. Or sometimes the cancer affects your immune system, not that much in breast cancer, but in other types of cancers like leukemia, lymphoma, the immune system is affected just by the cancer, not to mention the treatment, but just by the cancer. And the other problem that we see is that sometimes the side effects of treatment can mimic COVID-19. So we're always looking at, so a patient presents with diarrhea, that we always think about COVID-19 because you don't know, it could be a side effect from chemotherapy, but it could also be COVID-19. The diarrhea, nausea, or there are some drugs that can give you pneumonitis, inflammation of the lungs. Again, same thing. You think, is it COVID or is it just a side effect of one of the medications? So we have to keep this in mind always when we're making the assessment of the patient. And you can see here part of that study that I was mentioning about, The Lancet. It was published March 2020. And this is a small study and some information from patients in China. So of course, you don't know really how accurate this is, but apparently this was a good study. And you see here in this graph, you see the patients with without cancer. These are ICU admissions. These are patients that were intubated, that or they had significant complications to the point of death. Cancer survivors, as you see, is a little bit higher, the risk of complications. These are the survivors. Patients with active cancer on treatment, they do worse. And those are the patients that we're really trying to protect with all the things that we've done here in the office, and many centers are doing the same thing, trying to protect the patients that have really active cancers, because you see the outcomes are worse here as compared to cancer survivors and as compared to somebody without cancer. Of course, these, I'm not taking into account here the patients that have other comorbidities or high blood pressure, or they're older, or diabetes, things like that. Okay, so what have we done in the last 9 months? So everything changed. And at the beginning, when we had many cases, to the point that in Florida, we had days with 14,000, 15,000 cases. That was the peak of the disease. Right now, we're going between 1,000 to 3,000 cases a day, so much better. But at that time, the main priority was not to overwhelm the hospitals, but of course, provide the care that the patients needed. And I have to say that nobody went without the care that they need. But this, of course, translated in a lot of cancellation of tests, mammograms, routine mammograms, some visits. Patients were afraid of coming to the office. We had to delay some surgeries. We had to delay radiation. And some hospitals more than others. I think we were lucky in a way because we have several buildings. So we were able to really have the COVID building and then the building for surgeries. And so for us was okay. But there were many hospitals that they had to close surgery and they had to close everything else because the main priority was not to overwhelm the healthcare system. So the consequences of these actions, of course, delay in diagnosis. We've seen that already. There are patients that are coming to us, unfortunately, with more advanced disease because they didn't have that mammogram or they didn't have the scan when they needed to. So of course, that changes your prognosis when you don't come with on time. That's increasing a lot of the problems related to cancer. We also saw a big change in research. As you know, research is such a priority for us because that's how we're going to find a cure for breast cancer. But with research, we had to stop the clinical trials. Many patients couldn't come in, so all the studies were put on hold, and that's a big problem. As you can see here, the participation in clinical trials decreased significantly. So these are, for example, week by week, and the National Cancer Institute. And look, right before the pandemic, they were recruiting about 3,000 cases per week. And in May, it was almost in half. And for us, we didn't close the clinical trials completely, but we went case by case, like how urgent, how important is for that patient to participate on that clinical trial. And we had to get authorization case by case. It was not open, but it was not closed completely. So that was good too. So what did we do? Everybody got together, all the big associations in the country. So you see here, the American College of Radiology, NEPC, American College of Surgeons, NCCN, all the big association institutions in the country got together and said, okay, well, how are we going to do this? So we defined different categories: high priority, intermediate, and low priority. So what was high priority? Urgent care, that patients that needed to be treated right away. Intermediate was patients that it was important for them to get into treatment, but you could delay it a few weeks. And then low priority, those patients can wait. And what can we do to make sure they wait, but they're safe waiting and the disease doesn't get worse? So let's talk about that. So in terms of screening and diagnosis, so we had high priority and low priority. For example, if the patient came to us with a mass, with a palpable mass in the breast, skin retraction, nipple retraction, changes in the breast, that patient had a mammogram. Those we brought in and we did the mammograms. If there was a clinical evidence of recurrence, if any abnormal mammogram, we addressed. Low priority, maybe your screening routine mammogram got delayed a few months. We ask patients not to delay more than 3 months, but if it was due in April, okay, waiting until June, July was not the end of the day. Of course, making sure that the patient didn't have any symptoms and no concerns. Other tests that were low priority, for example, bone density. I can wait to make a diagnosis of osteopenia or osteoporosis in a patient. I can wait 3 months. So there were some tests that it was okay to wait, but the important thing to know is that if you needed your test, you got your test. And we did not delay care in patients that really needed a diagnosis to be made at that time. So again, there was care that was never delayed, and there was also care that was safely delayed. And now we resume because now we're pretty much acting like normal. But it's good to have these guidelines in place because we don't know what's going to happen, and the flu season is coming. So we hope that things are going to be good, but we don't know. So now we're better prepared. So care that was never delayed, you have all your curative intent. So patients that come to us and we have to give chemotherapy in order to cure them, or if the patient had more advanced disease, we knew that the chemotherapy was going to be extending life. Of course, those patients got treatment. So pretty much chemotherapy or and targeted therapy, or biological therapy, all of those we were able to give. Endocrine therapy is easy because that you do at home, and there are not a significant impact on immune system. Continuation of clinical trials, like I explained before, patients that are pregnant with cancer, those are always urgent for us, and we took care of those as well. And then patients that have advanced breast cancer, that have pain, that have brain metastases, that have, things that you can't wait. You have to treat right away. We took care of those as well. So again, care that was safely delayed, for example, a dose of Xgeva for osteoporosis. Okay, we can delay that one few months. There are some types of breast cancer surgery that we can delay. So if you have, for example, DCIS, which is a precancerous condition of the breast, we can put you on hormonal therapy, give you tamoxifen, give you Arimidex, Femara, one of those, and delay your surgery a little bit. That's okay. We know that those patients are not gonna progress. So again, case by case. And so what we call the low risk breast cancer surgery, those we were able to delay as well. So surgery. High priority was always all the complications: bleeding, infection, tissue necrosis after reconstruction, for example. Completion of, once the patient completed neoadjuvant chemo would be before surgery. You complete that, you can go to surgery. Of course, we were not going to delay that. Aggressive cancers, pregnancies. And in low priority, we included the patients that had benign lesions that needed to be removed for some reason, carcinoma in situ, so the pre-cancer. Reconstruction, many patients were able to have the breast cancer surgery, but they didn't do the reconstruction because reconstruction, of course, you can have more complications and you can have more delay in care. And so reconstruction will delay some cases. And also prophylactic surgery, which is a topic of interest to this group, of course. These are patients that had BRCA or whatever gene, another gene that increases your risk of cancer. The prophylactic surgeries, we delayed them until we felt that it was safe. Of course, making sure all the imaging studies were done and there was no evidence of cancer for those patients. So we were able to manage those as well. DCIS, pre-cancer, ductal carcinoma in situ. Most of these cancers are estrogen positive. So this is the type of cancer or pre-cancer that you can delay the treatment. So patients like these, they were not eager to have surgery right away because they were afraid to coming into the hospital in the middle of COVID. Those patients, we put on tamoxifen, we put on Arimidex, 3 months, come back, and now we're starting to do those surgeries. Those patients really, the risk of having a bad outcome is extremely low. So we treated them, and this allowed us to delay surgery until we felt that it was safe for them to go to a hospital. And if you had early stage breast cancer, of course, it depends on what type of breast cancer. So high priority was all the cases that needed chemotherapy before surgery. And we include there the triple negative breast cancers and the HER2 positive breast cancer. Intermediate priority, the cases that get hormonal therapy. Again, those are easy to treat. And low priority, the DCIS, like I discussed before. So again, it depends on the case. It depends on the case, and we go back and forth. The other tools that we use in order to know if the patient needs treatment right away or not is tests like Oncotype, or there's another one called Mammoprint. And this is a test that we do we analyze the genetic material of the tumor, and we tell the patient if they are at high risk of developing a recurrence or low risk. So in this case, for example, 32 is a high risk patient. That patient will get chemotherapy. We're not going to delay that care. But there's some other patients that have very low risk. Those patients, you don't need chemotherapy. So again, those are the tools that we can use to just spare that patient from chemotherapy, put them on hormonal therapy, and they don't need to go through the treatment in the middle of a pandemic. High-risk breast cancers, what we consider high risk, and they're not all high risk, but what we consider more aggressive cancers are the triple negative breast cancers, so ER/PR negative, HER2 negative, and or the tumors that are HER2 positive, or the tumors that are aggressive ER positive, HER2 negative, or have multiple lymph nodes involved. Those are the patients that we need to give chemotherapy before surgery, so those patients got their treatment during the pandemic. Because we know, in many cases, we know that it's the same to chemotherapy before or after. So if we feel that the patient could do the surgery now, send them to surgery. If you feel that the patient needs chemotherapy first, you send them to chemotherapy. So again, the surgeons were there working. What they did, for example, at Sylvester, is that every surgeon did 1 week a month. So they would go to the hospital, do a whole week of surgeries, and then come home and quarantine to make sure everybody was safe. And then the next week, another surgeon will take care of all the patients. And so they were taking turns to make sure the surgeons were safe. Of course, so we don't contaminate or infect somebody. So there was a lot of thought into this to make sure everybody was safe. Radiation, similar scenario. We have high priority, intermediate priority, low priority. High priority is, of course, complications. You have tumor in your spine that is causing core compression. That is a huge priority. Brain metastases, or you needed to do just the radiation for aggressive tumors. All those patients got treatment. Low priority, again, carcinoma in situ. You can delay the radiation 3 months and it's not going to affect your outcome. So everybody had a list of priorities and we went with that to make sure everybody was safe. In terms of advanced breast cancer, honestly, those patients, we never stop the treatment because these are patients that need treatment. They cannot wait for anything. So we gave them the chemotherapy, hormonal therapy, immunotherapy, targeted therapy. Those patients got everything. There are some drugs, so there are some classes of drugs, mTOR inhibitors, PIK3CA inhibitors. Some of them can cause immunosuppression. So we were very careful with some of them to make sure we were not going to cause more immunosuppression at that time. So there were some patients that we didn't do we didn't add these drugs to the treatment. We just continue with what they really needed at the time. And when we felt that it was safer, then we added these drugs. So again, it depends also what kind of treatment you're getting, and that's a conversation with your physician to see really what's causing the immunosuppression here and what do I need to be safe. So we had also a lot of rules to make therapy safe because you have to give the treatment, but then what? How do you make sure those patients that are getting chemotherapy are going to do well? So there were a lot of discussions about treatment decisions. So for example, if the patient had a choice of getting an IV chemo or an oral chemo, we would go with an oral chemo. Or if the patient needed steroids, you will go with a small dose of steroids, minimal dose of steroids, not to suppress the immune system. Some treatments you can give every 2 weeks or every 3 weeks. So we went with every 3 weeks so the patient didn't have to come to the office very often. So things like that. There's some room there for changes. Appointments, we tried to do a lot of the telemedicine visits, things that didn't require a physical exam. We did through video. And those are very helpful, and those are here to stay. I think patients are never going to go back to the usual. If there's something that they can discuss from home, why not? And in terms of self-care, of course, some patients needed to isolate for different reasons, but we were very careful with our patients to make sure they were not exposed to anybody else. And of course, we always encourage to stop smoking because it's bad for everything, including COVID. So side effects. So you see here, for example, a CAT scan of a patient that has all of these is bad infiltrates in the lungs. And that could be cancer, but that could also could be a side effect of one of the medications that we use. For example, there's a medication called everolimus that gives you pneumonitis. So you see this, and you don't know if this cancer, is this a side effect of the medication. So it's okay to go to a hospital. It's okay to come here. Patients should not be afraid. So there were many things that are hard to assess over the phone. So you have a swollen leg. That could be, a blood clot. So there's things that are urgent. A chest X-ray or a CAT scan like this. There's some things that are urgent. Go to a hospital. The hospitals, they have very good protocols in place to make sure people are really isolated and the patients that have COVID are in one side of the hospital. And so it's okay. We should not be afraid. If you require urgent care, just go. There's nothing worse than delaying your care and having a heart attack or having a pulmonary embolism and you don't want to go to a hospital. So the oncologist is always going to be involved in those decisions. So you call us and we'll guide you on what to do if there is something that you think is urgent. The virtual clinic visits, we're doing many of those. I would say that right now we're doing maybe half and half. And there are a lot of things that we can do through video. So we discuss side effects, we give test results, we discuss management of hot flashes, we discuss, you know, many things that are easy to discuss over the phone, and I don't need to do a physical exam. When I need to do a physical exam, I'll bring you in and we can do that. But again, there are many things, refill of medications, and one of the advantages is that right now I'm seeing patients from all over the world. And that's neat because before they had to be here. Now these open doors for us to be more proactive, and now this is accepted from the government down. So that was very important for us. So I'm seeing patients from all over the world. And the other thing is that sometimes family members, you have a family member in Spain, and they're able to participate from the discussion. And that's very important because right now that we're so isolated and everybody's, you know, at home alone, is at least that's your support system. So friends come in and that's your support system. So I think that's one of the advantages. And again, that's here to stay. We've made tons of changes in the clinic to make sure you're safe, right? So you see there, for example, you know, the plexiglass and trying to, you know, have the barriers in order to prevent the droplet transmission. Well, sometimes we have the face shield, of course, mask, everybody. Everybody's we do the social distancing in the space. And you can see here a little bit, some chairs are totally blocked, so patients don't sit next to the other. And the other thing that we've done is we have a system of checking in from the car. So there's a number, you call, you check in from the car, you tell, I'm in the car, call me when the doctor is ready for me. So then we don't have to use the waiting rooms. So I'm ready, we call the patient comes in, and we see him right away. So that's also good. You know, that we have to be creative, and that's how we've done it, and so far so good. When you come into Sylvester, you're gonna get a temperature check, you're gonna get some questions, the usual questions, have you been exposed, any recent travel, you know, the usual. We check your temperature, we give you a new mask, and you come. Visitors are not allowed right now. We'll hope to change that soon. Of course, if there are exceptions. Not everybody is able to come alone. So we have patients with mental illness. We have patients with, that is a big discussion of change of therapy, or sometimes even end of life care. Of course, those patients we're not gonna make, you know, come alone. But if the patient is otherwise healthy, we try to minimize exposure because like right now here I'm in Plantation, the first floor, we have a stem cell unit. So these are stem cell patients that just had stem cell transplant. Those patients are super high risk, so we try to minimize the visitors. But again, there's always exceptions, and we've done a lot of things to change. And then the other thing that we've been doing to help patients cope with all of these is our virtual Zoom services. And all of those services listed there, support groups, pet therapy, nutrition, music, dance, yoga, you name it. We have like a whole calendar every week. We come up with a calendar, and there are like 4 or 5 things every day that you can choose from. Again, we're trying to have patients engaged, something to do. This is for our mental health because we're all going crazy at home. So this has been a very good program. Everybody's welcome. You don't need to be a patient of Sylvester. You just register, or if you want the information, we can send it to you, and you just log in and get in any of those. So that's a great service that Sylvester is providing our patients. I think that was my last slide, and I will open to discussion or questions about anything.
So what we could do is we can open up for questions. If you have questions, you can raise your hand, or you can unmute yourself and feel free to ask Dr. Perez any questions that you have.
Hi, Dr. Perez. Hi.
Hi.
I was wondering if you could talk more about the risks in terms of getting radiation therapy right now. The risk that my doctor talking about was mostly just that it's more increased contact coming in for the daily. Is there any other risk associated? Because she wasn't, when I asked her about that, she didn't say there was any other risks from the therapy itself. It was more just that you'd have more increased contact because you're coming in so often.
Yes, and that's right. Most of the risk is really a healthcare facility. And even though we have a lot of precautions in place, there's always a risk, right? Because you never know with this disease. The immune system can be affected by radiation, not as much as therapy. So it's not the same, but there is some decrease in the immune system. But I think honestly, at this point, I will not delay any radiation. We're doing it. Just make sure you do the base, what I'm sure you've been doing all along, wearing your mask, washing your hands. If you want to be super careful, maybe a face shield again. But I will not delay radiation at this point. Maybe 3 months ago, when we had 15,000 cases a day, yeah, that's different.
Does anybody else have any other questions? Our audience is very quiet tonight. It's very different.
Because they're sick and tired of COVID. That's why.
I know. I was kind of hesitant, but I'm like, I had so many women reach out to me recently to talk about it. And I'm like, there's no questions.
No, the thing is that is still very relevant because COVID is here to stay. And I think some of the things that we've done are going to be here for a while. So I think it's relevant, even though, yeah, we hate the topic, we all do, but we have to know it, and we have to feel comfortable with what we're doing, and it's very important that we know what the hospitals are doing to keep everybody safe. Because you also, when patients come here, many patients say to me, like, wow, everything that you've done, you're so structured and you're so good, and because sometimes there's some places that they don't even check on you anymore. People are getting very relaxed, and we shouldn't. This is a disease that can be very serious, and especially in patients with cancer. We cannot take any chances.
Perfect. Are you sure nobody else has any questions? Perfect. Well, thank you so much for coming on, Dr. Perez. I appreciate your time and coming on and dedication to always coming to help women and gain knowledge on, the breast cancer world and the community, whether it's breast cancer month or not. We need to continue to educate throughout every month of the year.
Yes, true. Yeah. It's not just October. We work every day.
Yeah. I see a visitor for you.
Hello. Yes, I see my friend there.
Sandra. Hi, doctor. How are you?
Hi. ¿Está bien?
Yeah.
They're so much alike. Oh my God. It's like if they're not sisters.
Right?
Yeah.
This is Tracy, Sandra. Good to see you too. Good to see you.
Nice to meet you. I hear about you all the time.
He's been my rock throughout the whole time, and it's like this. So you know my story. So
yes, we lost our mom.
We lost our mom when we were teenagers. I was 13 and she was 16. So she's like my mom.
Nice to have her. That's for sure.
Thank you, Alejandra. Thank you, Tracy, for having me.
You're
welcome.
Thank you,
everybody. Talk to you later. Thank you.
You're welcome. Well, thank you again for coming on. It was great seeing